Hi, I'm Dr. Kavita Bapat. Today's topic is PPH bundle care. The postpartum hemorrhage, most troublesome, most dangerous, most dreadful, and most common and the most important cause for the maternal mortality. So today the topic is PPH bundle care, and the most important thing is not to stop questioning. That's Albert Einstein. Now, the postpartum hemorrhage, that the 5% of all live births, leading cause of maternal mortality and morbidity, and most deaths are preventable through the implementation effective intervention. The recent shift from the home births to the facility births across the low and middle income countries have changed the scenario of postpartum hemorrhage, but unfortunately, inconsistent and or a delayed use of effective intervention for prevention of treatment of PPH is another cause and the problem of maternal mortality, in addition to other systematic problem in health services, lack of blood banks, inadequate staffing. This is a special problem for our country. Then the third, these two things are, so the bundle approach has come. It is being designed to increase the uptake and compliance of the recommended interventions. Care bundle are differed from other care packages in that the compliance is achieved only when all the bundle's interventions are completed and recorded. We need teamwork, communication, cooperation are emphasized. Because of these, health system processes are required for quality and sustainability. So the bundle approach is very, very important. Bundle approach in a different time is a different way. In 2001, it is developed by the formal approach to bundle care. It increases the quality and efficiency of the care delivery. It is by the Institute of Healthcare. In 2012, it is for the prevention and the treatment and to provide the evidence-informed clinical care, and they have recommendations. So in the 2001, only the care and the care delivery, 2012, prevention and treatment and recommendations. But in early 2017, WHO recommended evidence-based intervention. It might accelerate the adoption and adherence to the guidelines. First step towards the goal is, number one is the adoption of the bundle care definition. Number two is a PPH intervention. And third is the selection criteria. And fourth is most important is the process of the development of two PPH bundles. Then the PPH approach in 2018 is another important point. It is a WHO technical consultation of the PPH bundle. It's a primary response to the PPH bundle, IV fluids, massage of the uterus, uterotonic medication, and tranexamic acid if less than 3 hours post-delivery. But in 2019, again, on the one hand, the bundle approach might clinically less useful if a large proportion of women with a refractory PPH are ineligible for the bundle application. On the other hand, if the bundle intervention are given to all the women with refractory PPH, that might be potential to overthrow the some women. So accepted definition of a care bundle is in which all interventions should be administered. If not all interventions are administered, the response of the refractory PPH bundle would be more similar to the care packages. So it's always there is a difference between the care packages and a PPH bundle care. So the prevention and recognition of the PPH bundle, the bundle intervention proposed PPH prevention included, number one is the uterotonics, number two is a controlled cord traction, number third is uterine tone assessment, and the experts agreed that the proposed bundles of the intervention was very similar with the active management of third stage of a labor package. On the elements, CCT, that's a controlled cord traction, was recently demonstrated to have little effect on PPH. So another important thing, there are so many challenges and solutions for the implementing of the PPH guidelines and solutions. Number one, challenge one is solution, early detection and a treatment of PPH. Delays detecting the PPH is a worrisome. Life-saving treatment not properly initiated. These are another important point. So the action line and the warning line are very, very important. At what time and how much blood loss is there and where to transfer the patient, how to detect that this is a PPH and what life-saving treatments are initiated. So this is a big challenge. So we need to treat the patient. The solution is early detection and treatment. Then the emotive is another important thing. The E motive includes E is early detection of the postpartum hemorrhage. Motive M stands for massage of the uterus. O stands for the oxytocin drugs. T is a tranexamic acid. IV is IV fluids. And E is the examination of the genital tract and escalation. And the treatment for the refractory. But the second challenge is, and the solution of the bundle is E motive is one of the solution of the implementation of the guidelines and solution. So delayed or inconsistent use of the intervention of the PPH management is the biggest challenge. Then role of uterotonics, it's administered methyl-ergometrine or ergometrine, other fixed combination of oxytocin and ergometrine, misoprostol. The preferred drug of prevention of the PPH oxytocin, 10 international unit, if unavailable, intramuscular ergometrine, and the fixed drugs combination of oxytocin ergometrine, if not contraindicated. If intramuscular or IV electronics are unavailable, given oral misoprostol. Second is the controlled contraction after delivery of the newborn. It is assessed that no other fetus in the uterus. Genital traction is applied to the umbilical cord with one hand and other hand applied the abdominal counter pressure on the uterus. Third is the postpartum abdominal uterine tonus assessment. Palpate the uterus, assess the uterus firmness, tone, and the uterus is soft, flabby, there may be indication of atony. Then isotonic crystalloids are administered starting 500 ml IV line 30 minutes with a continuing dose of 500 ml of isotonic crystalloids in 60 minutes. Tranexamic acid, again fixed dose, 1 gram tranexamic acid, 100 milligram per ml vial, 1 ml per minute within 3 hours of the diagnosis of PPH. If it's delayed, that's no use. But if it is within the 1 hour, the second dose of 1 gram can be given if needed after the 30 minutes. Then uterine massage, circular rubbing of the uterus achieved via the manual massage and of the abdomen, and it's typically sustained until the bleeding stops and uterus contracts. Then intrauterine balloon tamponade, the procedure entails the insertion of the deflated or uninflated balloon into the uterine cavity, then inflating and achieve the tamponade effect. Bimanual uterine compression, 2 hands, handed one over the anterior vaginal fornix, one behind the uterine fundus, squeezing the uterus between the hands. Then external aortic compression, applied close to the first level of the umbilicus, slightly to the women's left. NASG used of the temporizing measure, use of the bleeding found and treated. NASG is a lower body compression device made stretch of the non-preen, which close tightly with a velcro in the segments of ankle, calves, thighs, pelvis, and abdomen, and it is applied rapidly starting at the ankles. Then single dose of antibiotics in context to the placental retention, placenta should be extracted, and a single dose of antibiotics should be administered. Uterine artery embolization, if the major flayed, if unnecessary resources are available, the use of uterine artery embolization is recommended as the treatment for PPH due to uterine atony. Surgical intervention if bleeding persists, despite of treatment of uterotonics, conservative intervention, surgical intervention should be used without further delay. So the IHI defined bundle as small sets of evidence-based intervention for a defined patient population and care setting that when implemented together and result in significantly better outcome than when implemented individually. So this is the IHI definition for the bundles. Then care bundles are the improved patient outcome where adherence is high. The concept of care bundle is similar to the package and checklist. Again, we have to do the packages and checklists which have been used by the healthcare providers for decades and with a similar goal of standardization and expedient care. And the care bundle is again, we have the improved patient outcome by the supplementary care bundles may include widely used ABCS that is designed to help practitioner to remember in the sequence for the resuscitation, number of intervention packages together, such as active management of third stage of labor, that is AMTSL packages used to prevent PPH. Now, the first response to PPH bundle, the set of intravenous proposed, uterotonics, IV, tranexamic acid, uterine massage. High relevance rate and agreement from the experts for the implementation at the PHC and the hospital level. So the first response is at the level of PHC and hospital. We should be concerned there might be a barrier of implementation of many community settings and bundle might require a substantial amount of research such as the equipment, lack of equipments, the supplies, the training. These are the very, very important point when we worried about the first response to the PPH bundle and what are the health policies at that personal level of that community setting, at that PSC or at that hospital level. And what are the regulations, how it is working, how it should go like that. Again, the PPH second to the first response to the PPH bundle approved the bundle for the treatment of PPH due to uterine atony, hospital and PSC, communicated, implemented by the SBA, WHO. Approximately, they should be equipped and trained. The expert panel suggested acronym that might be used, the bundle such as Motivate or Motive 8. That's very, very important. Motive 8 is massage, oxytocin, tranexamic acid, IV fluids. These are the Motive 8 or Motivate. Then response to refractory PPH bundle following the set of intervention proposed by the response of refractory PPH care bundle. Number 1, continuous administration of uterotonics and isotonic crystalloids. Second dose of tranexamic acid because it's a response to the refractory PPH. Then LBT is another important thing. Then non-pneumatic anti-shock garment, NASG, and it was acknowledged that LBT or NASG may not be available in some settings. So why we are worried? That's an issue for the refractive PPH bundle. First, uterotonic, crystalloids, tranexamic acid already included into first response bundle and therefore did not need to be listed as a bundle components. Number 2, IBT is currently recommended by WHO but considered controversial owing to the recently published evidence. So another important point. And third important point, in cases where IBT or NASG not available, bimanual uterine compression and external aortic compression suggested for the bundle inclusion. For the country like India, we will more trust on the aortic compression and bimanual massage than availability of the NASG. So the issues of the refractory PPH bundle, again, this is a fourth, concerns of implementing all elements might result into the over-treatment of the woman with refractory hemorrhage. Those conditions was not worsening. And last, the area of contention was whether not to response refractory PPH bundle should be bundle conditional. Variable and progressive changes of refractory hemorrhage may make these conditions less appropriate for the bundle approach. So what should be the final care bundle? First response PPH, uterotonics, isotonic, tranexamic acid, uterine massage, and in initial fluid resuscitation performed together with IV administration of uterotonics. IV uterotonics not available, fluid resuscitation should be started in parallel with the sublingual misoprostol and other parenteral uterotonics. If postpartum injection context to the placental retention and placenta should be extracted. Single dose of antibiotics should be antibiotics. The final care is the response to refractory PPH, compressive measure, aortic and bimanual, intrauterine balloon tampon, and non-pneumatic anti-shock garment. But the important is continuous dose of uterotonics, isotonic diluted, second dose of secondary should be administered due to the application of bundle, and these are the things. So final care for the postpartum hemorrhage, apply both vaginal and cesarean delivery. Post-cesarean delivery might require modified approach for the following reasons. Uterine massage may not be effective. Uterotonics IV fluids are likely to be already in place. Modified bundle that address the unique circumstances and need post-cesarean bleeding should be developed and evaluated. Current WHO intervention, these PPH bundles are living bundles and will be re-examined as new evidence emerge during the process of updating WHO recommendation and guidelines. So factors should be evaluated, correction added on 21st January, feasibility, acceptability, safety, adverse consequences, effective relative to individual intervention, the opinion of the healthcare planners, practitioners, and users, cost effectiveness, impact should be studied at both the hospital and a PSC level and evaluate the value of bundle at different settings. Although both bundles are suitable for use in PSC and early adoption and ownership at the referral hospitals. And there may be need of the consideration of what bundle elements may be implemented if there is only one provider. So another important thing. So the discussion is basically this process included comprehensive literature review and list of evidence-based intervention and validated framework in the criteria in the guide of selection, WHO recommended condition. So the discussion is a limited set of evidence-based intervention are defined patient population, care setting, procedure, and treatment. So this is the leadership way of putting things, the what facilities are available, what is the national network integration, what PPH emergency response, how teamwork communication, what is the data monitoring and quality improvement is there, and what is the respectful maternity care is there. So these are the another important points. So teamwork evolution, facility readiness, network integration, data monitoring and quality improvement are the leadership things are there. So conclusion is to lead the definition of two care bundle facilities. The first response of PPH bundle comprises of uterotonics, isotonic crystallized tonexmic and massage. The response of refractory PPH comprises of all the four things plus NASG, biomanual uterine compression, and intra-uterine balloon tamponade. And advocacy, training, treatment, and communication use of the best clinical use where the practical should be there. So this is another very, very important thing. And the first response is the needs of further research for the feasibility, acceptability, and effectiveness, and identify the optimal implementation strategies. And for the secondary response to refractory bundle, there again we need a research. It should address the pending controversies and including the operational definition of refractory PPH and effectiveness of IBT device. Thank you so much for the patient listening. This today's topic is always a very, very important because it gives the PPH care bundle, again, the first response or the refractory response is there, it should be there, and one should take care while dealing with a PPH patient person. And in future, WHO needs to work more evidence-based, more feasibility, more activity on this subject. Thank you so much for the patient listening.